Abuse Skilled Nursing Facility Investigations. My name is Judy Andrian, and I'll be hosting the event today. The topic of our webinar will be focused on the occurrence of fraud, waste, and abuse among skilled nursing facilities. Our thought leaders will examine common billing, coding patterns, and claims errors, in addition to identifying providers that might merit review. We will explore what to look for when conducting reviews and discuss sophisticated analytics and methods which have been most effective in uncovering problem areas. So I'm just going to give you a quick overview of our agenda. At first, I'll review some of our webinar protocols. I'll introduce our speakers. We will review a background of the issues in skilled nursing facilities and then dive into some techniques used to identify payment errors. Finally, at the end of our session, we'll reserve about 10 to 15 minutes for questions and answers. So before we begin, let's start with a few housekeeping notes and protocols. Please note that your line will be automatically muted during the webinar. However, if you have any questions or comments, you can send those at any time using the question function located on the side panel. We'll address those questions at the end of the webinar, and if we don't get to those questions, we'll answer them via email shortly after. In the follow-up email, we're also going to include a link to a recording of the webinar. So if you feel you've missed anything, you can always review that later. So let me start by introducing today's speakers. Our first speaker is Roger Smith. Roger's worked in healthcare for 15 years. His experience ranges from representing a health plan in various contract and legal disputes to running a special investigations unit, founding a post-pay payment integrity company, to his current role, where he leads solution development for a $50 million healthcare-focused enterprise. Prior to entering healthcare, Roger practiced commercial litigation in the Northeast for 7 years. Our second speaker is Georgette Gutch. Georgette has worked in healthcare for over 30 years as a registered nurse and nursing home administrator. Her experience includes working as a floor nurse as well as home health, nursing home administrator, skilled nursing facility case management, RN MDS nurse, director of nursing services, and active participant on quality improvement policy and procedure committees in both hospital and skilled nursing facility settings for Medicare and regulatory compliance. So now I think we're finally ready to begin the webinar. So let's first welcome Roger Smith. Roger, it's all yours.
Thanks very much, Judy. So first, we want to just quickly, and Judy gave a little introduction and a little bit of our agenda, but the goals of what we'd like to do briefly today, and we have 45 minutes or so to do this, is define what skilled nursing care is, provide a little insight into the nuances of some of the terms and rules that apply, discuss some of the issues and challenges around reviewing and auditing skilled nursing facilities, talk about an example or two of some problems that can arise, and then some ideas about how you might address those from fraud, waste, or abuse angle, trying to target some of the specific things that can come up. First, we wanted to provide a little background around skilled nursing facilities, the spend involved. So this chart shows from 2009 through projections through 2016, overall spend in the United States on healthcare and then specific to skilled nursing facilities. So the first point is SNFs are running at a pretty consistent rate of about 5.5 to 5.3%. So over 5% of our total annual spend is on skilled nursing facility services. And although it's declining slightly, over the last couple years, the trend is actually upward. So if you look 2012, the increase in expenditures was only 1.3%. This year, expected to be 4.6%. Next year, 5%, and then going forward, really matching the overall trend in healthcare expenditures. So definitely a significant portion of expenditures and actually rising over the last couple of years. A little context in terms of the type of folks that are in SNFs and what the payers are involved there. So this chart reflects the primary payer entities, so Medicare, private pay, and Medicaid. Interesting to note that Medicaid is paying for about 63% of all individuals within a SNF. So you can see, whereas Medicare is only about 14%, the big difference there is that Medicare is usually the first payer. Most people that are in SNFs are elderly, but Medicare has benefit limits. Typically, once somebody is on Medicaid as the payer of last resort, Medicaid can end up paying for a much longer period of time than Medicare. So there's many more on the Medicaid rolls that are on SNFs. However, as this next slide reflects, Medicaid is only paying about 31% of all of the cost of SNF care, and that's because of the differential payment. Medicaid pays much less than Medicare or commercial pays, and so actually there's a lot of desire and interest by SNFs to treat Medicare patients, and actually it's where some of the challenges can occur. And as Georgette was telling me earlier, Medicare is almost sort of the gatekeeping entity for SNF care in our country. People come in first through Medicare and then transition to other settings. We wanted to ask a quick poll question before we get into some of the substance, and this is basically covering, sort of where is your company, where is your organization? Do you believe that you should be doing more to review skilled nursing facility services? There's lots of ways that organizations try to target issues in skilled nursing, and simply yes, no, or really doesn't apply. Folks can just answer quickly, and we'll see where the audience is. So, Judy, I don't know if we want to give it a minute or two.
Yeah, a few people still voting. We'll give it a few more seconds.
Sure. And there's certainly a bunch of different techniques that can be used. So there's folks who would do pre-certification. They could do post-payment reviews. There might be concurrent review of skilled nursing facility care. So certainly can approach this from various perspectives. And looks like a resounding answer of yes. We believe that we should be doing more with reviewing skilled nursing facility services. I assume that's partially why folks joined the webinar. So good. So we'll move forward. Judy, we're back on the presentation. All right, great. So just a little high-level introduction to SNFs, and then I'm going to hand it over to Georgette to get into more detail about some of the details of specific key terms, definitions, that kind of thing. So really, at core, SNFs are appropriate where a patient needs certain staff, and we gave it some examples here, RNs, LPNs, PTO, TST, that have skills, trained skills to manage, observe, and evaluate care on an inpatient basis. And there's two key components there. It has to be skilled care. It has to be not things that are, and we talk about below here, can't be custodial care. It has to be skilled, and it has to be something that needs to be done on an inpatient basis. So other care that could be rendered in the home, person should really then be treated in the home. So those are key requirements. The care has to be ordered by a physician, and then there are periodic assessments to evaluate whether the care should be adjusted. So the idea is that the care doesn't continue at the same rate and same level throughout. If that's not what's appropriate for the patient, there really should be some monitoring, and there's specific requirements for when those monitoring and those assessments have to occur. An example or two of what would be a skilled service that would require skilled nursing facility care inpatient is if a patient needs certain intravenous injections and those can't be managed in the home, if they need certain physical therapy, and again, they can't be managed in the home. And then care given by non-professional staff doesn't count. So there's a concept of custodial care, which often some of the elderly need assistance with things, activities of daily living, those kind of things. Those don't count. So the purpose of the care has to be to help the patient improve their health, to get better, function more independently, learn to take care of their health needs, and allow them to step down to a lower level of care, typically at home. Now, that's not always successful, but that's the intent of what SNF care is for. And in Medicare in particular, the result of that is there are limits on how long care will be covered, because the idea is eventually the patient should transition out of skilled nursing care into other settings. Georgette, if you want to talk a little bit about some of the key concepts involved, particularly with Medicare, that'd be great.
3-digit RUG score is calculated using some key elements of the MDS assessment. Represents the type and the intensity of the care the patient is requiring and or receiving. Stands for resource utilization groups, and there are 66 RUG scores. They represent different case mix rates and determine the daily payment rate to the facility for providing these types of services. The MDS is short for the minimum data set. It is an assessment tool that's used to measure the amount of care needed and delivered to the patient. There's various types of MDS assessments. The scheduled assessments are the required assessments. They are specifically required at definite intervals during a qualifying Medicare SNF stay. The staff must assess that patient and make note of any changes in the therapy or the care, then reflect it on the information on the MDS assessment. The regularly scheduled assessments occur for the 5-day, 14-day, 30-day, 60-day, and 90-day MDS assessments. Now, in addition to the regularly scheduled MDS assessments, there are COTs. They are the change of therapy. And every 7 days, while the patient is receiving therapy services, the staff must assess for any changes in that therapy intensity. Whenever the change occurs, a new MDS assessment must be prepared. When there is a change in the amount or intensity or type of care, an unscheduled assessment must be prepared. The provider must note when the patient stops receiving skilled therapy services, defined as 3 consecutive days without therapy, and prepare an EOT or an end of therapy assessment. So on a very broad overview, let's look at some of the Medicare requirements. First, the patient must have days left in their benefit period. They start with 100 days and limited per episode. There must be a qualifying inpatient hospital stay, no less than 3 days, and then the patient leaves the hospital. The day the patient leaves the hospital, it's not counted in those 3 qualifying days. There must be a doctor's order that states the services that are required and the specific professional personnel needed in order to carry out those services. It must also indicate that those skilled services are needed on a daily basis and that these services could not be accomplished in any other setting other than an inpatient SNF stay. The skilled services must be to treat a medical condition that they were treated for during that 3-day qualifying hospital stay and a continuation of the treatment that was initiated during that qualifying hospital stay. And finally, the services must be reasonable and necessary for the treatment of that particular patient condition. Some of the...
jump in. Oh, you want to... Go ahead, Georgette. No? Go ahead.
Oh, some of the common areas. Go right ahead, Roger. It's your turn.
No.
Sorry.
Yeah. I was going to say, I got ahead of
myself here.
You did, no problem. So one of the things about SNFs is it's intended to be for the episode of care, but that would be continuous typically. There are certain situations where a patient can leave and be readmitted to a SNF, and there's some requirements around when that will be permitted as part of the same episode, or if they need another 3-day qualifying stay. So if a patient leaves and they re-enter the same or another SNF, and they do that within a 30-day period, then they may not require that 3-day qualifying stay. Basically, the 3-day stay is intended to show that the patient had an acute episode or acute condition that required that SNF care, not that they've just deteriorated and want to go into a SNF. So there's sort of Medicare trying to have some independent checks on people being admitted to SNFs. Other interesting or other things to note are every skilled nursing facility is certified, and the certification looks at whether they have staff and equipment to give skilled nursing care and or rehab services and other related health services. So certainly important to check if you're looking at a SNF that they have that certification. And then the other concept here, we talked a little bit about this before, is custodial care. So Medicare doesn't cover custodial care if it's the only kind of care a patient needs. Custodial care simply is any care that helps the patient with usual daily activities, so getting out of bed, eating, bathing, dressing, using the bathroom. And it can include care that people do themselves, such as giving eye drops, oxygen, taking care of colostomy or bladder catheters. So, but the key here is custodial care is often given in a nursing facility. The question is whether the patient can do that themselves or if it's something that they need help with. And even if they need help with it, in order for it to count as skilled, it has to require skilled assistance. And there would be certain instances for some daily activities that might require skill, but typically that's going to be something that should not be counted for the skilled services at issue. So as we talked about, Medicare pays on using a resource utilization group, a RUG score, sort of looking at as a daily bundled payment for that episode of care based on the intensity of the patient's care. We'll get into a little more detail about that, sort of the type of care. In terms of other payers, there are some requirements that vary. So, for example, it is not always the case that private insurance requires an inpatient stay to trigger entitlement to coverage for skilled nursing facility. And the benefit may not be limited to exactly 100 days. So those are some things that certainly should be checked in terms of what the coverage is, but otherwise it's generally similar requirements in terms of what must be required. The patient's going to need skilled care, and if it's custodial care, it's not going to count towards that skilled care. And as we talked about before, it's almost certainly going to be that the patient needs to have that care on an inpatient basis as opposed to, for example, in their home or go to a doctor's office for that care or a PT's office for that care. Medicaid is the other, as we talked about earlier, primary payer and actually the largest, covers the most people that are in SNFs in this country. And Medicare really only, it's a payer of last resort, so it only comes into play when other benefits are exhausted. And generally, Medicare is first. Patient exhausts their Medicare benefits, then they transition to any private insurance they might have, and then last, Medicaid. And Medicaid typically requires that other assets be exhausted before Medicaid will start paying for skilled nursing care. So one thing certainly to look about, we don't cover it here. If it's a Medicaid plan, there's definitely reason to make sure that what happened in terms of exhaustion of those other assets. There's a bunch of legal requirements that vary by state around sort of looking through people that might try to be transferring assets to other people shortly before they go into a SNF or during their SNF stay to be able to argue that they've exhausted their other assets when in fact they were just transferred to a child, another family member, etc. And then the specific coverage requirements for skilled nursing facility for Medicaid do vary by state somewhat. They're defined by each state. They all have established criteria. but the level of care requirements have to provide access to individuals who meet the coverage criteria defined in federal law. So basically, federal law is, in effect, a floor. If somebody is eligible for Medicare, they're going to likely meet the Medicaid requirements. The Medicaid requirements may be slightly different, but they have to be basically the same. An example here is we provided on Texas. So Texas looks to see that the stay is medically necessary. It requires a medical condition so serious that the patient needs level of nursing care only available in an institution. So again, you can hear those same requirements. Nursing care, which is the skilled care, available in an institution on an inpatient basis. The doctor has to document the medical condition and prescribe skilled nursing services on a regular basis in an institutional setting. So again, the doctor has to order that care, and here the doctor has to recertify at least every 6 months that the patient continues to meet the standard. So a recertification provision. It might be slightly different from the Medicare requirements, but basic doctor order and recertification. And if the patient only needs custodial care, then Texas Medicaid finds that the nursing home stay is not medically necessary. So again, that concept of if they're only requiring custodial care, shouldn't be things that have to be done in a skilled facility. Now let's talk a little bit about the reimbursement methodology, a little more detail for Medicare. As we talked about, it pays based on a resource utilization group for each day. Medicare pays in full for the first 20 days, and then there's a copay basically for the balance of the days the patient's in up to the 100-day maximum. Providers would typically send in a bill monthly, and on that bill they're going to list the RUG score for each date. And those RUG scores can change. That's the idea, because there's those assessments we talked about, the scheduled assessments, the change of therapy assessments, et cetera, where they would have to do a new MDS and the RUG score would change. The RUG scores are a bundled payment. They're adjusted based on geography, wage index, those kind of things to, again, account for differences in cost of rendering the care. The RUG score is composed of 3 digits, as Georgia mentioned. There are 8 classification levels and 60 groups. What does that mean? So each digit has a specific meaning and tells you a specific thing. The first digit tells you the type of service that's being provided, and we listed the main ones here. So there's a rehab, rehabilitation, rehab plus extensive services, clinically complex, behavioral, reduced physical function, etc. The second digit indicates the level of service. The examples here are actually from the rehabilitation RUGs, which are the most common, ranging from ultra high to very high, high, medium, and low. And those are going to obviously drive a differential payment. Ultra high is saying the patient is receiving a very high amount of services, and low, obviously, not nearly as many. And then the third digit is an ADL score, which activities of daily living. And that reflects the extent to which a patient can take care of themselves on a daily basis, or do they need help with that. And the idea is that if a patient needs more help, then you have a higher RUG score, a higher reimbursement. The last thing to note is there is a default RUG AAA. For situations where a new assessment was required but not done and some other things, the main thing here is what Medicare in effect is saying is if you don't do an assessment, you need to do an assessment to tell Medicare what level of care you needed to provide and did provide. If you are required to do a new assessment and you don't do that, we're not going to give you the same rate. What we're going to do is drop you to a default rate. We're going to pay you something, but it's not going to be nearly what you would have been paid otherwise. And then very quickly, commercial and Medicaid. So commercial, it's really pretty dependent on how the payer has contracted for the SNF services. So that's going to be, as everything else, based on the contracting methodology they use. And there's several methodologies in use. Could be per diems. Those per diems actually, they've seen 2 types primarily. One is a flat per diem, same fixed amount per day regardless. And the other is what's called an intensity-based per diem. As more intense services, more are required, there would be a higher reimbursement. And typically there's a rev code, a revenue code, that will reflect the level of intensity of the services rendered on a given day. There are certainly some commercial and ASOs that pay using RUG scores because Medicare methodology is, pretty clearly defined and widely accepted. They just sort of piggyback on top of that. And as we noted, depending on the payer, it may not require a triggering inpatient stay. And then the other thing to think about is there can be various services not included in the per diem. So in Medicare, there's a concept of consolidated billing, which says that during a SNF stay, there should be a bunch of services that the SNF provides and nobody else should provide, and there shouldn't be a separate bill from a separate entity for those services. So examples would be a relatively extensive list of DME services should not be billed while the patient is inpatient at a SNF. Those would be duplicative to what the SNF is required to provide. Therapy services certainly you wouldn't expect to be billed while a patient is inpatient at a SNF. It can be slightly different for commercial is the point here. There can be some additional things that might not be covered in that per diem rate. That's really something to check specifically what the commercial payer rules say. And then Medicaid, it varies by state again, but there are several methodologies in use. So there are per diems, there's cost-based methodologies, and some of the per diems are even set based on the average cost across the state or otherwise. So some of the cost-based methods really look almost like when Medicare uses cost reports to pay hospitals for services. Similarly, they get an actual cost report from the SNF, and they set the rates based on that. Others, as it indicates here, states do a sort of blended average cost across the state. There are some Medicaid states that pay based on RUG methodology as well. All right. So now, Georgette, you can certainly talk, and I'm sure people are excited to hear about some of the common errors that can come up with a SNF stay.
Some of the common errors that we see are some missed or inappropriate timing of reporting those changes in therapy. As we discussed earlier, the providers must prepare a new MDS assessment when certain changes occur. And this is going to trigger a different RUG level and a different payment level going forward. Incorrectly counting those therapy minutes or the number of days for treatment, the number of treating disciplines, depending upon the criteria for that specific RUG level. Providers often overcount. Initial evaluation minutes. Do not count services that are not deemed medically necessary. Do not count. They do not meet the criteria. Certain types of therapy mode requirements. Always billing what the doctor ordered, even if it wasn't actually delivered. Times when the patient refuses treatment on a particular day, or the patient for one reason or another is not available, or the therapist was unable to attend that treatment session, the minutes cannot be counted. eSTEM. eSTEM is coded, it's counted if it's coded using the attended code. Otherwise, according to Medicare CMS RAI 3.0 manual, only the skilled portion of that treatment may be counted on the MDS. That means that the skills of the therapist are needed in order to determine proper electrode placement, establishing the appropriate settings and frequency, etc. The other times may not be counted. There are other modalities that only meet the skilled requirement in certain situations and must be supported in specific documentation. Non-therapy based, at times a therapy is scheduled, a patient is scheduled for therapy and refuses, or has some type of a functional limitation. That RUG score should reflect perhaps a C or a P, meaning clinically complex, or they reduced physical function, and not a rehab drug. It should be one of the other non-rehab drugs.
And Georgette, let me interrupt very quickly. The reason that matters, and we'll talk about it a little more, is rehab drugs are the highest paying drugs. So it's what skilled nursing facilities have an incentive to do is give rehab to as many patients as they can, bill a rehab drug for as many patients as they can. And so that's one of the keys to keep in mind is, are they claiming certain things are therapy when they really don't count as therapy? There are a bunch of examples that Georgette went through there, and there's a lot of obviously granularity in those examples. But eSTIM being the classic one, we all know, I think, that eSTIM, somebody sets it up and walks away, and the patient sits there for half an hour, 45 minutes, while the eSTIM does its work. The therapist isn't there the whole time, and that's the point. There are providers that claim that that is all skilled care, when in fact it's very clear that the only thing that the skilled person has to do is get the machine set up, get the patient set up, place the electrodes, set the levels, and then take it down at the end. So maybe one 15-minute increment is the fair amount. That's typically what we've determined. Whereas you'll see providers that are claiming much longer periods than that. So sorry, Georgette. Go ahead.
Not a problem. So on this next slide, we have broken down an example. The patient is admitted on March the 3rd. The first MDS is completed then on 3/19. Total individual therapy minutes in this particular example equal 310, which is equivalent to a rehab medium RUG score. Then 7 days later, on March 16th, the COT checkpoint happens. Now the individual minutes are 544. Now that is equal to a rehab very high and requires a COT assessment. But no COT assessment was completed by that provider to reflect that change in the therapy intensity. So the RUG score then becomes the default rate, AAA, from March the 10th until the next valid PPS or COT assessment is completed. Now, if the next valid ARD date was at 3/18, March 18th, the next COT checkpoint would be 7 days later, on March the 25th. This is a rolling 7 days. It's only interrupted by the completion of either a regularly scheduled assessment or a COT assessment or the cessation of the rehab services.
So, and the significant thing here is, so what happened, well, let me ask you this, you can say, Georgette, what happened because this provider did not do their COT?
When the provider does not complete that COT assessment, they are automatically paid at a default rate from the very first day of that COT look-back period until the next valid assessment is completed. So it can be.
They get paid a whole lot less. In fact, had they done the assessment, in this example, it's sort of reverse of a lot of things we see, but in this example, had they done the assessment, they would have gone from rehab medium to rehab very high. So they would have got, their payment would have increased. But in fact, they dropped to the default rate, which is even less than the rehab medium, because they didn't do that assessment. And the intent here is to have this continual monitoring, because as you see, therapy changes over time. I mean, I think you can look and see, in that period, down on the bottom where some of those red things are circled, in one day, the person had 35 minutes, then it goes up to 65, 63, 65, 63, then it's dropping back down to 55, 40, 45. So the things change over time. What the rules are designed to do is make sure that providers note and sort of pay attention to that and reflect those changes, as opposed to just sticking with the same level throughout an entire stay.
Absolutely correct. And
Okay.
the expected is that there will be that fluctuation.
Exactly. All right. So what we did on this next slide is we've done a lot of audits in this area, and we took so this is about 10 months worth of auditing experience for our clients, and pulled out on the top two grids there what was originally billed and we selected for audit, and then on the bottom what was the result after audit. So the first just thing to note is, so as you can see, we pulled 98% rehab rugs. In the upper left grid there you can see 177,000 of the 180,000 we pulled were rehab. Two reasons we did that. One is virtually all of the rugs that were billed are rehab, so it's a much overused code, and as I said, or rug score grouping, and that's because those pay the most. The other is there's a larger number of errors among rehab rugs than there are in others, and again, that's largely because there's an incentive to sort of get to those higher rehab rugs and scores. And then if you look, we've also shown the distribution of the level of intensity of the rehab rugs that were billed. So that the rehabs are the ones that have these UVHM, and then we showed the non-rehab rugs. There was only 3,200. But if you look at the percent of those rehab rugs billed at the ultra high, it's over 50%, 54%, and the very high is another 30%. So basically 85% of all their rehab rugs that we saw were billed with the highest level of intensity. So now if you drop down and look at what happened as a result of our audits, the first thing to note is almost half of them became default rate rugs. So the type A is those AAA scores. So the facility didn't do some kind of assessment that they were required to do to reflect the change or to reflect what was happening with the therapy of the patient, and the result is that they were required to be dropped to that low-level rug. But also of interest is the rehab versus distribution of the other rug scores. If you can see now, rehab represents 31.5% of all the rug scores after audit, and it's hard to know where those AAAs would necessarily fall, but certainly the P and the C are substantially increased as compared to where they were before. If you look based on the initial one selected, P was de minimis, 0.06%, and even the complex, clinically complex, was less than 1%. But now, clinically complex is 7.5%, and the P rugs are 12.5%. So big change in distribution of rugs and a big shift away from rehab. So definitely facilities that are attempting to increase their payments by getting to the rehab rugs. The other thing, if you look at the distribution of the levels of rehab rugs that came after audit, you can see that in the bottom right grid, and the ultra-high dropped from the 54% to about 33%, and the very high remained about the same. So combined, those changed from over about 85% to about 60%. So big decrease in the level of ultra-high, and certainly, problems in the very high rug scores as well. And there's the biggest shift is from high to low. I mean, the medium rugs, there was only 5% billed initially, and in fact, it then changed to over 15%. So a big upcoding or increase in the level of rug scores. Georgette, I don't know if you want to talk about, given some of these things we've observed, what plans should do or what they might do to try to be prepared to try to address some challenges that can come up in SNF.
Some things that might be of benefit is to establish some clear-cut rules and definitions of the requirements surrounding COTs, the MDS assessments themselves, EOTs, and eSTEM, and how that's going to play out. Whether certain things are defined as skilled or not. An example of Coumadin. The patient is on Coumadin, and that can be skilled initially to set up that initial appropriate therapeutic level, but not on an ongoing basis. Medicare states that drawing labs for general monitoring is not skilled. But many commercial plans do cover it. Assessment management triggers more payments. Would be appropriate perhaps for once a month, or if there's something that changes, but every one or two or three times a week would not be considered appropriate for, unless there is some type of a change in that patient's condition.
So the idea here is to have some clear rules about what counts as a skilled treatment, what are things that can be done on an ongoing basis, how frequently, assessment and management being a great example. You know, it is something that can be done, and same with the skilled care for Coumadin, but the frequency with which it's done is the problem. We see that at times, definitely. Sure.
So some things to look for. Rug findings that are more prone to error or not being reported correctly. Some are better than others at adjusting those rug scores and making the appropriate assessments and changes in their reporting. Some of the build ultra-high and extensive services, some providers bill those throughout the entire stay. Some providers use significant use of those higher rug levels, especially when the patient's or severity or other medical services don't appear to warrant those extraordinary services. Excessive care with lack of general improvement in the functional improvement of that particular patient.
And so some of the analytics, I think, are probably relatively straightforward from this. So looking for change in providers' behavior over time, patterns across patients with the levels of rug. There is some additional information that can be brought in terms of, and Georgette, you just referenced this, I think, what the member's history is, what their clinical condition is before they go in the rug. Does it seem like a situation where they're going to just need very high or ultra high rehab services throughout an extended period of time? Typically, you wouldn't expect to see that, but if you analyze providers, you'll see some of them appear to do that. Now, doesn't necessarily mean you want to audit every single member, because there could be some that are like that. Is there a way to zero in on certain members or patterns of members that fall into that category? The other is, again, certain rugs, Georgette is right, are more prone to error for other reasons or related reasons. It could be that, if you drill into some of those clinically complex rugs, you might find that, or we certainly found that certain rehab rugs really shouldn't be rehab. Well, is there a way to tell, based on something about the patient that that person really probably shouldn't be having rehab at all. Maybe they were having home care and they couldn't have any skilled home care. Well, then they probably shouldn't be having skilled care in their nursing home after they went into the hospital with an acute event. So there's a fair bit of information that can be sort of dug into on DX and other member history that can be insightful, I think, in terms of figuring out what are appropriate providers or what are appropriate claims for audit. All right. And I think with that, we are open to questions and answers. Let me see if there are any questions that folks have asked. I do have one. Georgette, one of the things you talked about was non-skilled care that sometimes people attempt to claim as counting towards a RUG score. Are there other examples that you would have that folks might want to watch for that really shouldn't count, like the eSTIM, or only count in certain circumstances?
For example, things like ice packs, heating pads, those types of things. Any individual can apply a heating pad or an ice pack. That doesn't require the specific skills of a licensed professional in order to accomplish that task. Those minutes are not allowed as a therapeutic modality. Sitting with a cognitively impaired individual is not considered a skilled service. Anyone can look over an individual to maintain their safety. Doesn't really require any kind of skill or professional licensure in order to accomplish that task.
Great. Another question about situations, if you could talk a little bit more about situations where patients might refuse or cannot tolerate therapy and what the impact of that might be.
When therapy is, the rehab department is recording their daily therapy minutes, they must indicate those particular situations that impact their treatment plan. For example, if that particular patient is refusing for their treatment session, they must indicate that on their treatment log. And those minutes, and particularly those therapy days, cannot be used then in calculating a RUG score. Not only does the minutes of treatment count towards that RUG score, but also the number of treatment days. So that's very important to watch out for those instances. If the patient refused, that cannot count as a treatment day.
Great.
Great. Roger, I have another question from the audience. The question is, what is the time frame for COT assessment, such as with improvement and decreasing therapy minute needs? How many visits or days of this decrease would trigger a COT?
Do you want me to go with that one, Roger?
I'm going to let you go, yes. You're the expert
Sure.
on the details of that.
The COTs are required on a rolling 7 days. What that means is, regardless of whether the therapy intensity increases or decreases, triggering a different RUG level of therapy delivered must be looked at every 7 days. That 7 days stops when either the COT checkpoint has been arrived at and determined that that individual is still at the same RUG level, or if that a regularly scheduled assessment happens, or a COT assessment is completed. Once the patient is no longer receiving therapy services, then the COT assessments are no longer needed.
Okay, I think that's it for the questions at this point.
Very good.
We get a lot of questions whether or not we will provide the presentation via PPT after the webinar, and yes, we will include that in our follow-up email.
Sure. And Judy, I'm sure if folks have other questions, they can reach out to us, and we can also answer those after the fact. But I'm glad everyone could join, and we appreciate the time today.
Absolutely. Thank you to everyone again. Thank you, everyone.